Hi, everybody. I think I know most of you in the room, but for those of you who don't know me, my name's Hannah Alsdurf, and I'm a doctoral candidate in epidemiology, and I work on tuberculosis with Dr. Menzies. So today I'm actually going through sort of a little bit of a different version of my protocol defense. So this is all on my doctoral thesis work. The title of my work is called Using Time and Motion Studies to Improve the Latent Tuberculosis Infection Cascade of Care. So I think most people in the room are familiar with quite a bit about tuberculosis, but for those of you who aren't, just a little background. So tuberculosis is characterized by active disease is characterized by having been infected with Mycobacterium tuberculosis. The World Health Organization estimates that around 10 million people in the world have active TB disease, and there's around 1.5 million deaths each year due to tuberculosis. And my research really, for my doctoral thesis, is centering on what's called latent tuberculosis infection. So this is actually a state where somebody has been infected with the TB bacteria, but they aren't active yet, and they don't have contagious disease as of yet. So again, the estimates right now are that somewhere around a quarter of the world's population is actually latently infected with TB. So that's sort of the reservoir, the base of that iceberg that you see in the image. And around 10 to 15% of people who have latent tuberculosis infection go on to develop active TB disease. So they become the 10 million cases that we have currently. So something that's important to note as well is that there are certain risk factors, particularly being immunocompromised, like HIV-infected individuals, or also children who are under 5 years of age, are much more likely to develop active disease. So little more context about my research is that the World Health Organization in 2015 outlined what's called the LTBI strategy. So the goal of this is to actually end the tuberculosis epidemic by 2035. And this was done in conjunction with the UN Sustainable Development Goals. And so the goal for the WHO, as I said, is to end TB. And to do that, they outlined 3 targets. But I'm going to center today, like all my research, on this one target, incidence of TB. So that would be fewer than 10 cases per 100,000 population. And part of this was done based on this modeling work that was done by Chris Dye and others to show that, as you see highlighted in red, latent tuberculosis needs to be on the agenda. So in order to reach the line of sort of fewer than 10 cases per 100,000, we have to move away from only treating active TB disease, which was essentially the priorities before 2015, to now incorporating latent TB preventive services. So again, with this LTBI strategy, one of the key pillars that my research is really centered around is this pillar 1, which is focused on integrated patient-centered care and prevention. So prevention is the key. And just to give you a little sense of how prevention works, for latent TB infections, anybody who has latent TB infection can be given 6 to 9 months of preventive therapy. It's isoniazid medication that's taken daily. And really, this was, again, focused on high-risk groups, so we really want to focus on HIV positive and children under 5. So a little bit more to get the context of my research is a framework that's called the Cascade of Care. So the Cascade of Care was actually really used initially in HIV literature, and what it was talking about was the patient trajectory or journey through the healthcare system. And so this was adopted to latent TB in particular. And what's really important to note is just to see that there's all these different steps that a patient has to come in to access healthcare. And at any point, for many reasons, a patient may decide to just sort of not come back. And so that's what we're really interested in seeing, what the barriers are for them accessing care. Furthermore, my research is happening in a large randomized controlled trial known as ACT4. It's a CIHR-funded trial that's run by Dr. Menzies. And it's a pragmatic cluster randomized trial in 5 countries. So I have them highlighted here in red and have the blow-ups of the different countries. So Canada, I think we all know where that is. It's highlighted in red in the top left. And then there's Ghana, Benin, Indonesia, and Vietnam. And so what's important to note is that the cluster randomization is actually happening at the healthcare unit. So within each country, there's different number of intervention or the same number of intervention and control facilities in each country. And the primary outcome for Act 4 is to evaluate the effectiveness of a standardized public health evaluation process that's then followed by selecting local solutions to help increase the proportion of household contacts, so people who spend a lot of time with someone who has active TB disease. And we're really trying to get them to start preventive therapy. So you can see I've outlined sort of the three key parts of the Act 4 intervention. So first is a standardized public health evaluation. And what that is actually the cascade that I showed you on the previous slide. It's each site is looking at the different losses that they have particular to their context to evaluate where they're losing the most patients. Then they go into a decision-making process. So all of this is what's called phase 1, and that's sort of the baseline part of the Act 4 trial. And then there's an implementation of locally chosen solutions. And those are solutions, again, that are targeted at their own barriers. So that's part of phase 2, or the intervention phase for Act 4. I should also say, if anybody has questions along the way, totally comfortable with you interrupting me at any point, so feel free to stop me at any time. Okay, so now I'm going to go into my research aim. So again, this is all happening under the umbrella of the Act 4 trial. So my main research aim is to determine the total projected health spending that's associated with the improvements in the cascade of care. And I'm doing this, again, through the use of the intervention, the Act 4 intervention, which is a package of standardized public health solutions. Okay, so my first objective was to systematically review the published literature and determine the pooled cumulative proportion of people who complete each step in the cascade of care, the LTBI cascade of care. So along with Dr. Menzies, we conducted a systematic review and meta-analysis. There were, you see the Prisma diagram, of just under 375 articles that were identified, and then we did a full text review of 110 articles. 58 studies in total were included, but that was actually 70 cohorts because some studies took different cohorts, like children under 5, and so we analyzed them separately. And then there were 750,000, or just under 750,000 participants. So it is important to note that this was the first time anybody had looked at the cascade of care in latent TB infection. So it's really an important study, and it was published in the Lancet Infectious Diseases in 2016. And you can see, so this is a different way of sort of imagining that cascade of care. It's more kind of like a waterfall. But in red, I've highlighted that the key finding was that fewer than 20% of people who were eligible actually got preventive therapy. But it also shows in a pretty dramatic way that while it's important that there's so few people getting treatment, there's major losses, and even at the beginning of this patient journey. So those people who are intended for screening are these household contacts, or primarily people who spend a lot of time around somebody who has active disease. And you can see there's a drop of almost 30% of people who should be screened to see if they have latent TB infection, who don't even get into the actual patient process. So we also looked at other steps that were associated with losses. So people who actually got a tuberculin skin test, most of you are probably familiar with the TST. Many of them actually weren't even referred for a medical evaluation after that. And then the people who actually did get a medical evaluation, there was another loss of people who didn't even get recommendation to start any preventive therapy. So we can see, again, this is justification for the need to have programmatic approaches and really target the barriers that are happening further up the cascade, not just people who aren't completing treatment. So the second objective for my research is to evaluate what's called a time and motion study and compare that to what's called a time estimation questionnaire. These are two instruments that I'm using to measure the proportion of healthcare worker time that's actually spent on latent TB related activities. So to explain a bit about the different instruments, the time and motion study is something that was actually developed in the 20th century for manufacturing processes. It was developed as a way to measure the time it took to do a specific motion, so a specific task. And it was really actually came about as a way to improve it, or to find efficiencies for a manufacturing system. So you can think of like an assembly line. They were trying to find ways to cut time so the cost would decrease. Now it's been adapted into many different settings, and now it's used by economists and researchers often to figure out the amount of time that's spent by people on certain activities of interest. And so there are a lot of different ways to do these studies, but what I'm using for this time and motion study in the Act 4 trial is what's called a continuous direct observation. So you're having another human being watching that person continuously throughout their entire workday. And I'll explain a little bit more about that in the next slide. But basically, just to know there's other ways where you can just take certain intervals of someone's time, but we are actually following them throughout the entire day. And so what we do with that is then we estimate the proportion of their time that's spent on pre-categorized or predetermined categories. So we've set active TB patients, latent TB patients, and then all other patients are categorized separately. We also are looking at any other clinical activities that the healthcare worker might be doing, and as well as like training and administrative tasks that they're responsible for. So with our study, we've actually designated what's called an economic research assistant, an ERA, at each site. And that they're basically a different type of research assistant because they're really focused on the cost components and this study, this TAM study for ACT4. So they take the TAM measurements, which means they actually sit next to or outside the office of the healthcare worker throughout their entire day, and they literally write down every single minute of activity. Now, for confidentiality reasons, they don't go into the patient room with the clinician, but they basically confirm the type of patient that came in, as I said, from the categories we predefined. So each time the patient leaves, they'll confer with the clinician to make sure that they categorized it as the correct type of patient encounter. So at baseline, we had a minimum of 5 staff members do an ERA at each site. And again, it's a one full typical workday. And so it was all types of healthcare workers, doctors, nurses, social workers, anybody who but they had to work at least one day a week in tuberculosis research. So that was sort of the criteria. And as you can imagine, there are ethical considerations, right? So what we did was we really explained to each healthcare worker, or the healthcare workers at each site, that they were free to not participate if they didn't want to, but those who were interested and eligible, meaning that they spent time in TB each week, provided us with verbal consent to participate. And then we also made sure that through these trainings that they understood that all their responses were confidential. None of the information, none of the data was actually given to supervisors or managers. It could not be used in any way for performance reviews. And furthermore, as I mentioned, so we're writing down the entire time, and I'll show an example in the next slide, but things like breaks, for tea break, going to the restroom, you can imagine people might change their behavior, but we did clarify with them at the beginning that all that time was removed from our analysis. So we really encouraged them to kind of have a typical work day. So, taking breaks as normal. The TAM forms, we also explained to them, were stored at each site in a secured lock cabinet. And furthermore, all information was then transmitted to me just directly from the ERAs at each site, and all the data was anonymized. So there was no way to identify individual healthcare workers. So this is an example of what just a snapshot of part of what the Excel form looks like. So it was a standardized form with drop-down menus to encourage, better data collection. But basically what you can see is that we get like these total times. So, 20-minute break for tea, they could write comments, they didn't always. But if, for example, I want to look at some specific latent TB related task, which is identifying contacts of someone with active TB, well, what you do is we have the minute breakdown. And so you can actually look at, I know from the TAM that it's a nurse, and so I look at that nurse's time, and I see it's 17 minutes. And so, for example, the salary scale in Vietnam is that it's 2 cents Canadian per minute for a nurse's salary in Vietnam. So you just multiply it out. So essentially, that patient encounter was, or that step in the Cascade was accounted for 34 cents in terms of costing. So this is the kind of costing that I'm using, and the precision that I get from the TAMs really enables me to get precise information to calculate the cost for the different activities, latent TB activities. So just a little time, I'll go over briefly the timeline for how this is done, just in case it's of interest. Basically, just to say that actually we started in April of 2016. I did a training on the TAMs with the PIs at each site, where there was a site investigators meeting here in Montreal. And then I conducted on-site trainings in Ghana and Benin in August of 2016. And then I did Skype trainings for all the other sites. We piloted the TAMs in November and December of 2016, got a lot of feedback from the sites, and then made some revisions. And finally, between January and, I should say, March of 2017, there was, that was the initial baseline measurements of the TAMS. So it happened at both intervention and control sites for healthcare workers at every site. We then got data back in April and May, and we revised the forms that summer and did some initial data entry and analysis. So from there we did some revisions. And then basically, well, and I should say, so the phase 1, as I mentioned before, of ACT4 was sort of ongoing between August of 2016 and August of 2017. So that was all the baseline data. And then phase 2, where the sites started to implement the solutions, began in August of 2017. And so I conducted refresher trainings in Ghana and Benin in November, and then also via Skype for the other sites in December. And currently all the sites are actually collecting their phase 2 TAMS. So the TAMS for the solutions phase are post-intervention. And we're aiming to have the data collection completed by the end of March, so hopefully we can start entry and analysis in April of this year. So moving on to the second part of my second objective, so I've gone into a lot of depth about the TAMS, but I haven't talked yet about the time estimation questionnaire. So what I'm aiming to do in part 2 of my second objective is to actually determine the overall difference in the estimates of time for using each instrument as an evaluation of the human resources required for this intervention. So the time estimation questionnaire is something that we're using basically for one main purpose, which is the TAMS are the gold standard. However, as I've explained, they're extremely costly and they require a huge amount of human resources because you have to have somebody watching somebody else through an entire day. So we tried to see if there was a way to use a questionnaire where healthcare workers would self-report their estimations of their time to see how well that actually measures their time. So we're really using 4 simple questions. We tried to make it very kind of basic, but to try to see if they're able to estimate their time well. So we asked them how much time they think they spent on TB services that day, and then the proportion of time they think they spent on latent TB services that day. And then we're asking them to think back to 1 year ago to see if they noticed a change in their work activities, and if it was an increase or a decrease in their time. And if so, kind of by how much. Now that's a rough estimation of how much. It's, is it half a day, a full day, you're doing more TB services. So it's obviously an imperfect way to do this, but we're trying to at least see if they're able to give us some estimate. So as I said, it's shorter, it's cheaper, and there's fewer human resources required for a questionnaire. So this is just to show you kind of the time points that we're collecting them. So we have the TAMS in phase 1 baseline and in phase 2, and then this time estimation questionnaire is actually happening the same day as the TAM in phase 2. And then we're following it up 1 month later with the same time estimation questionnaire to see also if there's been a dramatic change. So if a healthcare worker is reporting a very different proportion of time within that month, then it also gives us a measure of how reliable their answers are. Yeah, sure. 1 day, yes. Okay, so we asked them it has to be a typical day that they worked, and actually what happened was the ERA had to set this up with the person ahead of time. And so we asked them if there's something that happens, they actually had to note that on the form, and they were asked to stop the TAM and reschedule for a day that was typical, like if they get called into surgery or something. Yes, but it is still only 1 day. I mean, that's the other component of it. But so with the time estimation questionnaire, we're trying to see whether or not, as I said, it's a good predictor of the proportion of time spent on LTBI. So the way that we're comparing this is kind of twofold. Firstly, we're going to look at the same day. So we actually see from their own estimation. So if a healthcare worker says, I think I spent about 5% of my time, or 1 hour out of 8 hours on LTBI, then we'll use their response, and we can actually compare it directly to the precise number of minutes that we have from the TAM. So we have an estimate of how well that predicted the actual time. And then, as I mentioned before, we're looking at the change in time, so pre-post intervention, and so that really relies on this question about whether or not they can self-assess that there's been a change in their time, and we can compare that to the TAMs that were done on them in phase 2 to phase 1. Okay, so moving on, my third objective is to estimate the cost of the change in proportion of healthcare worker time that's spent on latent TB activities that result from the ACT4 intervention. So I just pulled out a snapshot to kind of give you an example. Now, this isn't real data, it's just more illustrative. But so you see we have all the steps in the cascade, and basically there's a lot of different components that are associated with each step. But I'm looking at the personnel costs for each step. So if, for example, it takes one nurse 15 minutes to do a contact investigation and they're paid $1 a minute, it's $15 for that step, right? So from there, I can then calculate the increase in their personnel costs. So basically I have that person's time in phase 2 and in phase 1. And so I essentially can add up all those different steps from step 1 to 7. So say for nurse 1, it's $250 after the intervention for them to do all of those steps. But in phase 1, when they did it, it was only $100. So the total cost, the change, rather the increase, is $150. And then this is useful because what we can do is we can actually calculate a per contact cost. Because what we're looking at in this cascade of care is to see how many additional people go through the cascade of care. And so, for example, if it's $150 extra and there's 100 contacts that go through, then it's $1.50 in addition for every contact that the system puts through and gives more LTBI services to. The other thing that I'm aiming to do is look at the negative costs of the intervention. So the negative costs are sort of a term used to think about what you're taking away from other programs. So, for example, many of these healthcare workers are working in HIV some point during the week, and they may be working in maternal child health, other programs. So we want to see what time is actually being diverted from those healthcare programs. And so we've asked them about how much time they spend on average per week in other health programs, and we'll see if there's a shift in that, so we can see what the sort of negative impacts of the intervention are, because ultimately a healthcare worker can only work a certain set number of hours in a day and in a week, and so likely by increasing certain services you may be detracting from other program services. So my last objective builds on all of this to actually it's sort of in a way it's almost a secondary part to the objective 3, but it's really looking at the total personnel costs for the program strengthening as actually a measure of the active TB cases. Because while throughout this presentation I've been talking about the number of contacts of active disease, typically TB programs do not gather that data, at least not systematically, but they are required to gather the data on the number of people who have active TB disease. So this for me is kind of a more important measure for health systems and health programs to actually be able to use to justify latent TB strengthening by kind of giving an actual cost per additional active TB case, because that gives programs information that they already have on hand, so they can really extrapolate out to know how much it would cost on average. So again, I sort of went through all the steps, but you can see if it's $65 and you have 10 additional active TB cases, then it's $650 per additional person with active TB who's part of the program. So some of the limitations of my work, I sort of touched on them before, but basically with healthcare workers, you only have, you will have repeated measures, but not for everyone, because it is a job and people are free to come and go, and many people leave jobs. As we know, it's not like you can retain people indefinitely. So there is sort of this real world limitation that some staff members have left their posts at each site, and also additional people have come on. So a way that we've addressed this is that, for example, if in one site there were 2 nurses to begin with and there's only 1 after the intervention, then the nurse who has stayed on, we're actually doing 2 TAMs in the phase 2. Now, again, it's still on the same person, but at least we're getting more sort of equivalent number of time points. And also we are taking measurements for everyone who comes on board, who consents and agrees. And then the second main concern is that there is potential for a Hawthorne effect. Anytime that somebody is being watched, they are likely to change their behavior, to have better behavior. And so the ways that we've sort of tried to address this is, firstly, as I mentioned, we've explained to everybody that the pauses, breaks, all that data is removed. None of this information is given to their supervisors, so we're trying to encourage them, and we do say specifically that we want them to go through like a normal day. And we're also using the same ERAs in both phases, so there's some familiarity with the person who's taking the measurements. And also we're anonymizing all the code codes. So for each healthcare worker. So basically, I don't know which individual it is. It's just an anonymized code for each person. So there is that kind of other level of confidentiality. So some of this use of TAMS. It's not traditionally used to look at changes in proportion of time throughout the whole day. It's been done, but not that commonly. And when people do TAMS in this sort of continuous direct observation manner, it's typically been in nursing, and it's usually like 10 or fewer TAMS because it's so resource intensive. So we have the advantage of a lot of healthcare workers across all sites. For example, in Vietnam, because there's just a very large workforce, and they were all willing to participate. There were 20 healthcare workers in the control sites and 20 healthcare workers in the intervention sites. So we have quite a large, robust number of measurements. As I mentioned, the TAMS are the gold standard, and so it's a good comparator for the time estimation questionnaire. Thirdly, as I mentioned, it's part of a larger randomized controlled trial, so both for generalizability of results, but also then as a means to control for confounding. I think this is a good design. And most importantly for me is that I think we are really providing some key costs to TB programs. Like if we really want to get to this goal of ending TB, and we really do want to take seriously the need to provide preventive treatment, then we have to be honest about what the costs are going to be to the healthcare system, because that's often what sort of drives the choices that are made in healthcare systems. And so I think we have site-specific costs, we have site-specific salary ranges, so we're really able to give both. I can get the sort of overall cost, but really each site is able to have their own specific tailored cost, and from there they can estimate what the real cost of scale up would be to their program. So I went faster than I thought I would. But anyhow, I want to thank everybody there were so many people who worked on this, but there were a lot of help from the site PIs and coordinators, and all these economic research assistants have done a huge amount of work. It's really a lot, and they've been wonderful. So with that, I'll take any questions. Yes, Jonathan. Go. Yes. Yes, tell me. Yeah, it should be per person. Yes. And actually, I did change that late last night, so thank you. It's good. Yeah.
My other question was, you guys were looking at the opportunity of adding in the
yeah.
Mm-hmm. It's not necessarily taking away time to be there, but maybe taking care of other
yeah.
responsibilities. How are you going to assess the negative impact of being able to healthcare level that increases in,
yeah.
More because people aren't getting care they usually do.
Right. Yeah, I mean, honestly, we're not. It's not within the scope of my research. I mean, I think that it is something we're all sort of concerned about, but there's just like feasible limitations to what we can do. I mean, that said, I don't know, like, if in the broader scope, if Dr. Menzies is planning to kind of have some way to assess that at different facilities, but I think it also really depends contextually, right? Like, because in Canada, for example, like the TB clinic is pretty much an entity to itself. And even in Ghana, it's very much TB HIV clinic, but it's not really part of it. And actually, even in Benin, it's a respiratory health. But because in Benin, it's a larger like respiratory health facility, there may be decreases in services to patients with asthma. Like so I mean honestly, that's not the scope for my research, but I think it's an important thing to think about. To be really frank, like we had one question about whether or not they've how much time they spend on other activities, like other kind of programs. And so even that, I'm not sure, it's subject to all the things like their own bias and recall and whatever. So it's not like we've measured it in a very systematic way, but I think it's at least helpful to gauge on some level what the potential shifts are. But it's not precise. Yeah.
One more curiosity.
Yeah, sure.
Do you guys have baseline activity?
Yeah.
Yearly basis?
Yep, I have it. I have a bunch of slides.
Yeah.
Hold on.
I think that'd be like
it's here.
That's anyone looking to
yeah.
Go in or planning to see what it has.
Yep, totally. Right. Totally. Yeah, that's a really good point. So these are the numbers for like each site. Well, okay, so Indonesia has 8 puskesmas. I didn't put all of them up, but basically, like we had, that was actually part of the inclusion criteria for the sites to see that they had a certain number of active TB cases. Obviously, Canada is a little different because, well, it's a CIHR-funded grant, and it's also like important for us to have data on a developed country as well. So that is sort of the outlier. But in terms of the other sites, we definitely have the active TB cases. So I think you're right. Like that's a really useful way to think about kind of what we can see from the like it's demonstrating the effectiveness of the prevention, right? Like that you're not seeing as many active cases. So it's not. It's beyond. It's. I think it's not. It's beyond my scope again. Yeah, but. You know, I haven't talked with Dr. Mendes about that in particular, but I imagine he's talking about that for sure. But we can discuss further. No, it's a really good point. Like I was thinking about it as I was making the presentation, but it's true. Like I haven't had a conversation on that particular, but I think it's a really important way to demonstrate what we've done. Yeah, so you can good. Spur on the research. Any other questions? Okay, well, thank you all for coming and listening to me. I appreciate it.